Everybody, I'm going to be speaking about this month's journal club at ECU Nephrology. The journal we have chosen this month is Bardoxolone Methyl and Kidney Function in CKD with Type 2 Diabetes. This was published online by the New England Journal of Medicine in June 2011. The lead author was Pablo Pergola, who seems to be a leader in the field of bardoxolone methyl and its effects on chronic kidney disease. This journal was based on a phase 2 double-blind randomized placebo-controlled trial, which had enrollment from May 2010 and study ended in December of 2010. It was a randomized placebo-controlled trial, as mentioned before, sponsored by the Rayeta Pharmaceutical Company. Design was done by the first author and representatives of the sponsor. Data was reviewed by Data and Safety Monitoring Board. So a little bit about the background of this paper. So chronic kidney disease is associated with type 2 diabetes and is one of the leading causes of kidney failure in this country and across the world. We know from histology and studies that both inflammation and oxidative damage contribute to the disease progression of chronic kidney disease in type 2 diabetics. Bardoxolone methyl is an oral antioxidant that modulates inflammation. It seems to be a derivative of oleanolic acid, which is found in many plants in the tropical regions of the world. Previous study, which was published earlier this year by the same first author, had a daily administration of bardoxolone methyl for 8 weeks, significantly increasing the estimated glomerular filtration rate in 20 patients with type 2 diabetes. So, how does bardoxolone methyl work? So, it activates this KEP1 NRF2 pathway, which seems to interact with the cysteine residues on KEP1, allowing for NRF2 translocation and upregulation of many cytoprotective genes, inhibiting pro-inflammatory and nuclear factor kappa B pathway. Now, this study, we had 227 adults, all 18 years or older, with chronic kidney disease and type 2 diabetes, with an eGFR of 20 to 45, which were either broken up into a treatment group or a placebo group. Patients were screened by 2 measurements of their eGFR, approximately 5 days apart, and the enrollment period was 21 days. Patients had to be on an ACE inhibitor or an ARB or both for at least 8 weeks with a stable creatinine. Exclusion criteria included type 1 diabetics, uncontrolled diabetics, non-diabetic kidney disease, hepatic dysfunction, and cardiovascular events within the last 3 months. Patients were selected from 43 sites all across the United States. Randomization was done with the risk stratification of eGFR less than 30 and greater than 30, and a urine albumin to creatinine ratio greater than 300 and less than 300, and uncontrolled diabetic with a hemoglobin A1C of greater than 7 versus a controlled diabetic with a hemoglobin A1C of less than 7. So they originally enrolled 573 patients were screened for this study. 227 were randomized, and we'll go back to this slide in a little bit, but I just want to go over the groups. So they split the group into 3 treatment groups and 1 placebo group. All groups are distributed equally and as you can see, the treatment group was 25 milligrams, another treatment group was 75 milligrams, and another treatment group of 150 milligrams. Now, what is good to notice is many of the patients were discontinued in their treatment groups, but however, only 3 patients were started on dialysis from any of these groups. And we do have a large amount of patients that were discontinued with adverse events, death, and a loss of follow-up as well. And the amount of patients that actually were able to tolerate the dose that were prescribed to was noticeable. As you can see, only 14 patients ever ended up on 150 milligram tablets for a total of 52 weeks, while many of the patients who were supposed to be on 150 milligrams ended up with 8 patients were on 25 milligrams and 18 were on 75 milligrams, and you can see that across the board. So the way they did this was everybody was started on 25 milligram tablets, and dose adjustments were made every 4 weeks up to the first 20 weeks. Patients' EGFR was measured on baseline, then again every 4 weeks for a total of 52 weeks, a total of a year. 4 weeks after the last dose of bardoxolone methyl was given, another measurement of the EGFR was done. All labs were done by a central laboratory. The primary outcome was a change in baseline EGFR by the MDRD equation compared to placebo at 24 weeks, and then again the change at 52 weeks. Also wanted to check the baseline urine albumin to creatinine ratio at 24 weeks and 52 weeks compared in the treatment group versus the placebo group. And again, we wanted to check baseline levels of serum creatinine, BUN, phosphorus, uric acid, magnesium, potassium, bicarb, hemoglobin A1C, and intact PTH at the beginning, end, and middle of the study. So as I mentioned before, you had 3 treatment groups, a placebo group, and a placebo group. All were equally distributed. And you can see this, that it was pretty well distributed. You have approximately the same amount of patients in each group. You have the same age range. You have this same amount of racial and ethnic disparity. And weight and BMI was quite equal amongst the groups. Also was pretty good was the length of time the patients had diabetes was almost equal in all the groups. Note, you want to notice that almost 98% of the patients were on ACE, ARB, or both. And approximately the same amount of patients had equal amounts of albumin to creatinine ratio in their urine. So we will go back to that other slide where we see that patients, because they were stepping up, they were not ever able to get to their final dose. Where you have 15 patients in the 75 milligram group that only made it to the 25 milligram group. So we'll talk about the results of the study. There was definitely a significant increase in the mean EGFR at 24 weeks, and this was maintained at the 52-week period in the 3 treatment groups of bardoxolone methyl compared to the placebo group. The change between the EGFR in the 25 milligram group and the 75 milligram group was significant. However, there was no statistically significant change in the EGFR between the 75 milligram group and the 150 milligram group. There was no significant change in the baseline of the placebo group at 24 weeks or 52 weeks, and we can see that in this graph quite well. You see the placebo group is orange, where you can see it's pretty much flatlined throughout the study, while you can see the treatment groups, all 3 of them, at the first 12 weeks to have a rapid increase in EGFR, and then they start to plateau out. As you can see, the 75 milligram and the 150 milligram group kind of stay around the same, while the 25 milligram group is a little bit behind them. So the placebo group did have almost more than half of the patients had a decrease in EGFR at 52 weeks, while only 20% of the 25 milligram group had a reduction in EGFR, 21% in the 75 milligram group, and 27% in the 150 milligram group. And you can see that here, where greater than 50% of the placebo group had an increase in EGFR, while the others are closer to 20%, and they're bunched in together of the treatment group. So a 25% reduction in EGFR is a significant amount, and 13% of them of the patients in the placebo group had that much of a reduction, while only 2% in the combined treatment groups had greater than a 25% reduction in EGFR. And you can see here, we can see the patients with greater than 25% reduction in estimated GFR, and you can see you go all the way up to in the placebo group almost above 20, while it stays closer to 10 patients in the treatment groups altogether. So 4 weeks after the last administration of bardoxolone methyl, this is at 56 weeks, the EGFR remained above baseline for the treatment groups, and this was also found to be statistically significant. There was a significant increase in significant decreases in the level of BUN, phosphorus, uric acid, and magnesium in the treatment group compared to the placebo group at about 24 weeks and then at 52 weeks. This was inversely correlated to the increase in EGFR. However, we did not see any changes in the potassium, bicarb, intact PTH, or glycosylated hemoglobin. So we can see here, as you can see between the placebo group and the bardoxolone methyl group, you do have statistical significance of decrease in creatinine, and you have a decrease in BUN at 24 weeks, and you have a decrease in serum phosphates. Now, interesting to note, the level was decreased, but not at the same significance at 52 weeks. Now, uric acid, we also see that was decreased throughout the 52 weeks, and the magnesium had actually decreased throughout the 52 weeks. Now, of note, we can see the urine albumin to creatinine ratio actually went up in the treatment group compared to the placebo group. Now, you see no changes in the potassium, bicarb, or intact PTH. And the hemoglobin A1C did not change. Now, you do see a significant change in the weight between the treatment group and the placebo group. So, you had the 75 milligram group and the 150 milligram group. There was a significant increase in the urine albumin to creatinine ratio at 24 weeks and at 52 weeks. The changes were positively correlated to the EGFR at 52 weeks. And when the medications were discontinued, the albumin to creatinine ratio returned to baseline after drugs were discontinued. So, and here we have a list of the adverse events, and you broke it up between the different treatment groups, and you do see many things were similar with the placebo. However, we do have muscle spasms, hypoglycemia, increased ALT, and GI side effects to be significantly different with the treatment group. Now, the muscle spasms were primarily involved in the calves and resolved with the discontinuation of bardoxolone methyl. There was no correlation between the ALT or low magnesium levels with these muscle spasms. The ALT did peak at 2 to 4 weeks after initiation of the treatment and resolved after the patient was resolved as the patient continued to take the drug. ALT was persistent in one patient that developed post-hepatic obstruction, and 2 patients had liver biopsies done to elevated ALT. Now, these 3 patients here were deemed to have elevated ALT unrelated to the study. Now, we can break it down to what patients discontinued the medications because of their side effects, and you can see how many that were. And blood pressure did decrease in all study participants, but this was not statistically significant. And weight reduction did occur in all study participants as well. This was also not significant, and we're not really sure if the action that would have caused bardoxolone methyl to assist in weight reduction, and that's something that needs more further investigation. So you can see here you have the analysis of the patient's BMI in the treatment group, how much it reduced at 52 weeks with bardoxolone methyl. And then you also have here where the treatment, so what we have here is we also have here the change in EGFR compared to the weight change, and so you see that there seems to be some measure of correlation between the weight change and the change in EGFR. So, the conclusions of this study. Treatment with bardoxolone methyl for 52 weeks led to a sustained statistically significant improvement in the estimated glomerular filtration rate. So, patients were all receiving medical care for their chronic kidney disease, including ACE inhibitor and/or an ARB. Now, you can see the change in the first 12 weeks of the bardoxolone methyl group, and then it remained at a console level, suggesting there probably was a short-term effect during the first 12 weeks, which was followed by a longer-term effect. But the treatment groups had an EGFR above their baseline at 4 weeks after the last dose. This is almost 17 times the half-life of the study drug. So this may suggest that there may be a long-term effect of bardoxolone methyl past its treatment. The treatment group had increased in urine albumin to creatinine ratio, and the study suggests this is because this is due to increased glomerular filtration and decreased tubular resorption of proteins. But I'm not sure how valid this statement can be. I think we need more further studies for that. So let's discuss this a little bit further. So this study it seems to be very groundbreaking and for many reasons, but really there was no assessment of the kidney function other than an MDRD, which is a calculated equation. There was unable to determine if there was an actual renal functional improvement or this just improved lab measurements. I suggest further studies should show that bardoxolone methyl include a renal scan or a 24-hour urine study at the beginning, middle, and end of study to see actually what happened. Another question would be, did blood pressure improve renal function? 98% of the patients were on an ACE inhibitor and or angiotensin receptor blocker. Statistical analysis was not done to see if renal function improved independent of blood pressure improvements. So I guess I would suggest to the authors if they could go back and try to analyze that and see if they were independent of each other. Does bardoxolone methyl improve renal function by blood pressure instead of or in addition to the antioxidant effects that it proposes? Weight loss was found in the treatment group. But there was no measurement of muscle mass, which determines the BUN and creatinine. So this is another part of the study that could have been done better. If they had measured muscle mass, we could have figured out how much of this creatinine was real. And does bardoxolone methyl actually improve renal function by weight reduction in any way? Also, there was no real assessment of the tubular function in these patients. There was no measure, and this would be interesting to know if there is actually an effect on bardoxolone methyl's effect on the tubules. So, at the end of the day, what do we learn from this study? Does bardoxolone methyl prevent patients from needing renal replacement therapy, or are we just treating lab numbers? How effective is this drug in non-diabetics? And for all of this, long-term studies are needed for this. And all this was a very good study, but it probably needs further investigation. Thank you very much.